really great slate of presenters through the 6 scientific sessions plus the health equity session that are eligible for the competition. So on behalf of my co-distinguished moderator, Dr. Erivelto Volpi, and I, we would like to welcome you. I have a couple reminders before we begin for the presenters and those who are going to be discussants. First, we'd like to remind the presenters to keep to their allotted time as a sign of respect to your fellow presenters. The moderators will notify you if your time has expired and ask you to quickly wrap up the presentation if you go over. You will have a pointer up here to be able to advance and go back on your slides. We do not have a laser pointer for you to be able to use for your presentation, so just be aware of that. Second, we ask that audience members who have a question during this discussion of the period, please to come up to one of the microphones, the 4 microphones that you can see scattered around the room. Please clearly announce your name and institution prior to asking your question so that the recorder we can record that clearly for the surgery issue, the discussion. And inform the audience if you have any conflicts of interest as well, please, if you are related to the presentation that you're discussing. We ask that you be as brief as possible to allow ample time for the presenter to respond. As we proceed in the first session, I also wanted to let you know that we'll have 4 distinguished moderators during this year's meeting. The first will be Dr. Erivelto Volpi, who I'll introduce in just a moment. Then we'll have Drs. Fiamun Mariaku and Sanziana Rahman as the co-distinguished moderators during the health equity session tomorrow, and Dr. Saray Parangi will be our final distinguished moderator during scientific session 6. So our first distinguished moderator today is Dr. Erivelto Volpi. He's a well-known thyroid surgical oncologist from Brazil. He is one of the leaders in the burgeoning field of interventional endocrinology. And so I'd like to welcome him to the podium to give his distinguished moderator presentation. Thank you.
Good morning. Thank you. It's a great honor to be here. I wish to thank you, the organization, for inviting me. First of all, I want to say that I am a surgeon. I love to do thyroidectomies, okay? And but when we start to talk minimally invasive procedures, we need to change our mind in how we see thyroid nodules in many thyroid diseases. Okay. So in the last 20 years, there is an increasing interest in minimally invasive therapies in benign nodules and initial thyroid cancers. These recommendations are based on most thyroid nodules are benign and stable. And less than 10% of these nodules will grow during the time. And of course, for well-selected thyroid cancers, these minimally invasive treatments has also been proven effective. There is a common situation in our office. Sometimes we have a patient that come to us and say, "Oh, doc, I have a thyroid nodule. Is a benign nodule. It's growing. This nodule boring me, but I don't want to take out this nodule because my thyroid works well. I don't want to take pills for the rest of my life." So we can offer for these patients. There is another alternative. Yes, there is. In some situations, we can offer minimally invasive treatments. There is a long way from what we have now. In 1990s, ethanol was proposed as an alternative to surgery, but he has poor results in solid nodules. It's a good option, a very good option for cystic nodules. And at the beginning of the century, there was the first description regarding laser in treating advanced thyroid cancers, and with promising results for benign nodules. In 2006, there was the first report in the use of RFA in thyroid nodules. And 10 years ago, just 10 years ago, the first paper on microwave ablation. So when we adopt a new technology, it's not easy for us surgeons. It's hard for us to change our treatments because we have very good in what we do. We do very well, we have good results. But when we face a new technology, we need to be conscious about what we can offer. And at the beginning, there are innovators, I suppose, now, in most countries, we are in the era of early adopters, so we are visionaries. And there is a huge numbers of publications in literature regarding the use of minimally invasive treatments. And as you can see in the blue line, RFA, it's the most studied because it's easier to master, is cheaper, and with the best results. So that's why we use, in most of the cases, RFA. So if we have this technology, why don't we use this technology more frequently? There is a very interesting paper of a survey of ETA that showed that only 5% of its members perform thermal ablation therapy, and only 13% refer these patients for specialized centers. The main reasons are the lack of access, the lack of experience, and the absence of guidelines. That's why many societies got together and published last year a consensus regarding the use of these therapies for benign and malignant nodules. And why we need to give this technology in our toolbox? Because the most surgeries, the most thyroidectomies in the US are for benign diseases. And now we have the patients looking for a better quality of life. And they search for this. They search for new treatments. They go to the internet, go to the Facebook, go to the Instagram. They search. They have groups on Telegram searching for the best results. And these new technologies are safe and effective to treat these nodules. And as Dr. Beck from Seoul used to say, this is an excellent option for most benign nodules. It's effective, it's safe, can avoid hormone therapy, hospital stay, and general anesthesia. And it could be repeated as many times as necessary, and is an outpatient treatment. Before I finish my presentation, 2 or 3 words about the use of therapy ablations for malignant disease that could represent a new path between active surveillance and surgery. As you can see here, micropapillary thyroid cancer treated by RFA. And we know that active surveillance is a very good management of initial thyroid, low-risk thyroid cancers. However, the proportion of patients that give up this line of management is about 1/3. And this recent review shows that the patient anxiety is the main reasons for the patient's decline active surveillance. And when we talk about surgery, as I said before, we are very good surgeons. We do great surgeries. We save our patients. But we know that we have some issues related to surgeries. If the patients don't want a scar, more recent procedures like transoral and robotic thyroidectomy cause an increase in the cost. And even in experienced hands, complications like vocal fold palsy and hypoparathyroidism can occur. These tumors, these initial tumors, have a very good prognosis. That's why recent guidelines support less aggressive surgeries like lobectomy. But even in these surgeries, the patient could need hormone replacement after the surgery. So if you compare the quality of life of these patients with initial tumors with radiofrequency with surgery, you will see that the results, the efficacy of the radiofrequency is the same with less adverse effects. So for very selected, very carefully selected patients, the outcomes are the same and the quality of life is better. So it's a good option also in some very well selected recurrent metastases of papillary thyroid cancer. So, of course, we need more studies regarding these new technologies. And I want to wrap up my presentation with these messages. Thermal ablations are a good and efficient treatment for most benign thyroid nodules. In my humble opinion, should be considered the first-line therapy. Of course, more research is needed before we use this as a routine for micropapillary thyroid cancers. But we should encourage the discussion and incorporation of these therapies in our toolbox. It's very important that us, as surgeons, give this technology with us. And it's mandatory also education to guarantee over-treatments in benign nodules indolents that won't need any treatment, and to treat advanced thyroid cancers that you want to offer any benefit for these patients. Thank you so much.
Thank you, Dr. Volpi. We are going to launch right into our presentations, and I'm going to invite Reagan Collins to the podium. She'll be presenting on the impact of social determinants of health on thyroid cancer mortality and time to treatment on behalf of McManus, Kuo, Liu, Lee, and Kuo.
Good morning, everyone. Adjust these just a little. Good morning, everyone. My name is Reagan Collins, and I'm a medical student at Texas Tech. I'd like to thank the program committee and the AAS for the opportunity to present today. I'll be presenting our work evaluating social determinants of health in thyroid cancer care. We have nothing to disclose. Over 43,000 new thyroid cancer cases are diagnosed each year with a high estimated survival rate around 98%. Despite this overall excellent prognosis, several studies have identified disparities in the presentation, management, and outcomes of patients with thyroid cancer. For example, minority patients with thyroid cancer present with more advanced stage of disease, receive suboptimal surgical and medical treatment, and have worse outcomes. Race ethnicity, however, is not the only factor that may contribute to disparities in care. Social determinants of health, defined by the World Health Organization as the conditions in which people are born, grow, live, work, and age, have been proposed as additional upstream factors that may influence disparities in care. Healthy People 2030 groups social determinants to encompass 5 domains. These include economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. The first 3 will be the focus of this study. Among thyroid cancer patients, the individual social determinants of low education, low socioeconomic status, and insurance status are associated with more advanced stage at presentation and a lower likelihood of receiving guideline concordant care. Although many studies have assessed the relationship between race and stage at presentation, treatment, and outcomes in thyroid cancer, few take into account the social determinants that may be driving these associations. Thus, the role of social determinants, as well as their cumulative influence on thyroid cancer care, is not well defined. Identifying the relationship between social determinants and thyroid cancer care is integral to identifying at-risk patients who may face barriers to receiving appropriate care. We aimed to assess the individual and cumulative impact of social determinants on mortality and time to treatment among patients with thyroid cancer. To do that, we conducted a retrospective review of the National Cancer Database from 2004 to 2017. This database collects data from approximately 1,500 Commission on Cancer accredited facilities, representing more than 72% of newly diagnosed cancer cases nationally. Patients with papillary, follicular, medullary, or anaplastic thyroid cancer were included based on their ICD code. Data collected included demographics, histologic subtype and stage, comorbidities by the Charlson Comorbidity Index, facility volume quartile, overall survival, and time to treatment, where time to treatment was defined as time from diagnosis to first therapeutic treatment. The social determinants of health collected included income quartile, which was based on the median household income for a patient's area of residence. Education quartile, defined as the percentage of adults in a patient's zip code who did not graduate from high school. And insurance status, defined as the patient's primary insurance carrier at the time of diagnosis or treatment. A count variable was then created for patients in the lowest quartile of each social determinant, as shown here. We then examined the bivariate associations between these three social determinants and time to treatment, adjusting for race. All three had statistically significant associations with longer time to treatment and thus justified the creation of a count variable for the overall number of social determinants of health. To create this overall count, the adverse social determinants of low income, low education, and lack of insurance were summed for each patient to give a cumulative number of adverse social determinants of health ranging from 0 to 3. Univariable and multivariable Cox proportional hazards model were then used to assess the association of each demographic variable and individual social determinants with mortality and time to treatment. Given the significant interaction between race and the social determinant of health count variable, both overall and race-stratified models were used to assess the association between cumulative social determinant of health count and time to treatment. Kaplan-Meier curves were then used for data visualization and to assess differences between groups. This first table summarizes the adjusted analysis for overall survival. Here, a hazard ratio greater than 1 indicates a higher risk of mortality. On adjusted analysis, non-Hispanic Black patients had a greater risk of mortality compared to their white counterparts. Compared to patients with private insurance, those with Medicaid, Medicare, or no insurance also had a greater risk of mortality. Similarly, compared to patients in the highest income quartile, patients in the lowest income quartile had a greater risk of mortality, while there was no difference based on education quartile. Finally, patients with a longer time to treatment had a greater risk of mortality compared to patients treated within 90 days. This table now summarizes the adjusted analysis for time to treatment. Here, a hazard ratio less than 1 indicates a longer time to treatment. Compared to white patients, Asian Pacific Islander, non-Hispanic Black, and Spanish or Hispanic patients had a 16%, 19%, and 9% higher likelihood of longer time to treatment. Uninsured patients had a 25% higher likelihood of longer time to treatment compared to those with private insurance. And patients in the lowest income quartile received treatment more quickly, but still had a greater risk of mortality, as shown on the previous slide. Finally, patients in the lowest education quartile had a 16% higher likelihood of longer time to treatment than patients in the highest education quartile. This slide shows the Kaplan-Meier estimates for time to treatment for each social determinant of health count. Time to treatment increased with the addition of each adverse social determinant. So here, the red line on the bottom shows 0 social determinants of health, going up towards the purple and blue line, which shows all 3 social determinants. When compared to patients with no adverse social determinants, patients with 1, 2, or 3 had a 10%, 11%, and 34% higher likelihood of longer time to treatment. This slide now shows the subgroup analysis by race and ethnicity. In contrast to white and Asian Pacific Islander patients, we observed that Black and Hispanic patients were most impacted by each additional social determinant of health. Among Black patients, compared to no adverse social determinants, having 1, 2, or 3 was associated with a 9%, 7%, and 28% higher likelihood of longer time to treatment. Similarly, Hispanic patients with 1, 2, and 3 adverse social determinants had a 17%, 18%, and 33% higher likelihood of longer time to treatment. This study is not without its limitations. This was a retrospective cohort analysis of a large database, and the findings should be understood in that context. The database does not include information about recurrence or recurrence-free survival, so the main outcome assessed here was overall survival. And finally, the social determinants of health captured in this study reflect only a small portion of the various social determinants, including things like safe housing, transportation, racism, language, and health literacy, that may also affect access to care and thyroid cancer outcomes. In conclusion, education, income, and insurance status are all key social determinants of health that impact time to treatment for thyroid cancer patients. Our study shows that an increasing number of adverse social determinants leads to a higher likelihood for longer time to treatment for patients with thyroid cancer, which in turn is associated with a higher risk for mortality. Future work evaluating interventions to mitigate the effects of these upstream barriers to care is essential to ensuring all patients receive optimal and timely care. I'd like to thank my PI, Dr. Kuo, my co-authors, and I'll now take any questions.
Thank you, Dr. Collins. This abstract is now open for discussion. Please remember to announce your full name and institution and any conflicts of interest you have before asking your question. We'll start in the front over here with Dr. Wilhelm.
Scott Wilhelm, Cleveland, Ohio, Case Western, no disclosures. Dr. Collins, very nice study. My question for you in terms of, obviously you show that these social determinants of health increased your time to treat and therefore your mortality. Did you guys also use the NCDB to look at whether or not part of this related to distance traveled for patients and therefore kind of looking at the concept of are we actually contributing to this with silos of care and patients having to move further to get adequate treatment either before or after surgery? Enjoyed your presentation.
Thank you. That's a great question. And I'm not a doctor quite yet. I have a couple more years ahead of me, but I appreciate that. So regarding distance traveled, we did not include that in the analysis. Whenever deciding what social determinants to include, we really were focusing on that framework of the 5 domains. And with distance traveled, it's possible that patients who may actually have more resources may travel farther because they're able to do so. They're able to travel for more specialty-specific care or seek out alternative treatment options. So we didn't feel that that would really capture the social determinants based on that framework we had initially decided on. Thank you.
Let's go to the back on that side.
Cardi from Pittsburgh, no COI. Lovely presentation of an excellent study. 6 or so, 8 years ago, the famous editor of a famous surgical journal proposed to the board during the board meeting that that journal no longer take any papers of this type stating the problem unless they also provided answers or suggestions about how to fix it. So a number of us were in the room. While I consider that opinion to be flawed, you're all over this. What ideas do you have?
I don't disagree with the statement, actually. That's one of my pet peeves is whenever the papers identify the problem without positing possible interventions. So based on our data, we see, first off, education. That's impacting patients' ability to receive optimal care. So in that regard, I think, from a provider level, we can consider things like health literacy, culturally competent care, whenever you're talking to your patient, being cognizant of their different backgrounds, their beliefs, and even in the EMR, social determinants of health are starting to be captured on that. So taking a look at that information in EPIC and acknowledging that whenever you're trying to consult your patient, and realizing that those may be barriers that the patients have to their care. I think also in terms of insurance, we saw that that was a big factor impacting time to treatment. So it's easy to say expansion of healthcare, but expansion of healthcare can definitely make a difference here. So thank you.
Let's go to the back on the right, my right side here, and this will be the last question for the discussion. I'm sorry for everybody who was unable to answer questions.
Courtney Ballenhead from UW. I have no conflicts. Very nice talk, interesting and important topic, particularly since we definitely need more research and understanding how to fix stuff. But to piggyback on Dr. Cardy's question a little bit, did you all talk about doing a formal mediation analysis as opposed to just a primary causal analysis? So we found that the hazard ratio isn't always as informative as it could be for figuring out how important something is as a target for intervention. But if you actually break down the causal pathway, you can get a sense of how the important factors interact and affect your outcome in terms of relative importance, and then start to prioritize based on that what the intervention might be. So just curious if you guys had talked about it at all.
Yeah, that's a great question. It's not something that we've looked at yet, but I think that's a great point. Really getting down into the details of which exact factors have the biggest impact. Things like structural equation modeling can provide some of that mediation analysis where we can really discern which factor it is that has the biggest impact on time to treatment. So that's definitely something for future work. Thank you. Okay, thank you.
Next, we'd like to welcome Federico Palacardo to the podium. He'll be presenting on radioactive iodine is not associated with improved disease-specific survival in classic papillary thyroid carcinoma greater than 4 centimeters confined to the thyroid. On behalf of Lee, Greenberg, Egan, Beninato, Zarnegar, and Fahey, and Finnerty.
Good morning. First off, I'd like to thank the Society for giving me the chance to present our research. My name is Federico, and I'm a medical student from Weill, Cornell. Oops. We have nothing to disclose. In 2009, the ATA put forth the following risk stratification system for papillary thyroid carcinoma based on a risk of recurrence. This three-tiered system was developed due to the poor prognostic value of previous staging systems, as evidenced in a number of studies. This system has proved very useful when it comes to guiding decisions regarding radioactive iodine therapy. For instance, in the high-risk group, radioactive iodine is strongly recommended, as it has been shown to both decrease the risk of recurrence in this study by Gray, as well as decrease the risk of death in this study by Moten. On the other hand, in the low-risk category, there has been no shown impact of radioactive iodine on overall survival or recurrence, which has led the ATA to recommend against it in this category, as well as stimulate people to publish papers on whether we are overusing it in this population. In the intermediate risk category, there is conflicting evidence concerning radioactive iodine. In 2013, the study by Nixon proposed the idea that we be selective with this therapy in this subgroup of patients. In 2016, the study by Kim in South Korea proposed the idea that radioactive iodine may actually not decrease the risk of recurrence. And more recently, in 2020, this paper by Wang did a SEER-based study and found that radioactive iodine is associated with an improved disease-specific survival. So while the evidence for radioactive iodine within this risk category appears to be growing, the benefit has yet to be clear-cut, especially in the tumors that are at the lower end of the intermediate risk spectrum. For our study, we decided to focus on this row from the 2015 ATA guidelines. These tumors are categorized as low to intermediate risk and are intrathyroidal without any nodal or distant metastases. As you can see, radioactive iodine has conflicting evidence in studies, and there are no studies that looked only at this subset of tumors. We believe this study is important because from 2000 to 2018, the incidence of tumors greater than 4 centimeters increased and then stabilized. Concurrently, the mortality for these tumors also rose within this time frame. Tumor size has also been implicated as a risk factor. In this study by Shin, we saw that size greater than 4 centimeters increased the risk of recurrence with a hazard ratio of 3.99, as well as decreased cumulative survival, as seen in this Kaplan-Meier curve to your right. This led to our question. In otherwise localized papillary thyroid carcinoma, does larger size warrant radioactive iodine administration? And thus our aim was to examine the effect of radioactive iodine on disease-specific survival in patients with intrathyroidal papillary thyroid carcinoma greater than 4 centimeters. We used the SEER database, which allowed us to look at our primary outcome of disease-specific survival. We looked at all adult patients diagnosed with classic subtype papillary thyroid carcinoma, diagnosed between 2004 and 2015, and further filtered for tumor size greater than 4 centimeters and confined to the thyroid. We excluded any patients who did not receive surgery, who got radioactive iodine prior to surgery, or received other forms of radiation. We further excluded any tumor sizes greater than 15 centimeters, as we deemed these to be likely outliers or possible coding errors. We then collected our data. Our cohort had 740 patients who received radioactive iodine and 555 who did not. We saw more patients that were 55 years and older in the non-treatment group, representing an older cohort who did not receive radioactive iodine. We saw a higher proportion of total thyroidectomies in the group that received radioactive iodine as compared to those who did not. We also saw that patients who received radioactive iodine had more tumors with multiple foci within the thyroid compared to those who did not receive it. However, this may be explained by a higher proportion of patients with unspecified tumor extension in the non-treatment group. Lastly, we saw a longer median follow-up in the patients who received radioactive iodine, consistent with receiving more therapy after surgery. This is our multivariable Cox analysis, and we did not see a significant association of radioactive iodine with disease-specific survival. What we did find is that being older, namely 55 years or older, increased the risk of cancer-specific death with a hazard ratio of 3.54. We also saw that tumor size was a risk factor for cancer-specific death with a hazard ratio of 1.04. We also constructed a Kaplan-Meier curve to further analyze this relationship, however, continued to see no significant association as seen by our log-rank test p-value. We then conducted 2 analyses from subgroups based on the risk factors that we discovered in our multivariable analysis. Here you see a sub-analysis of only patients 55 years and older. However, we continued to see a non-significant association of radioactive iodine with disease-specific survival, and tumor size continued to show as a risk factor. Our other sub-analysis had a higher tumor size cutoff of 5 centimeters, which was the median in our group. However, we continued to see no association of radioactive iodine with disease-specific survival, and age continued to be a risk factor. Overall, we did not find a significant association of radioactive iodine on disease-specific survival, both in our cohort and subgroups, but we did identify age and tumor size as risk factors within this subset of tumors. This study did have its limitations. Using SEER was beneficial because it allows us to look at disease-specific survival, but it lacks information on disease recurrence, which some say is a better outcome to analyze in a low mortality malignancy such as this one. We also lacked information on radioactive iodine treatment, as well as molecular tumor markers that could have helped further risk stratify these tumors. Lastly, there are no granular details in these large databases on the reasoning behind treatment decisions, which may have been helpful in this study. In conclusion, radioactive iodine administration in these classic variant papillary thyroid carcinomas that are greater than 4 centimeters and confined to the thyroid did not have a significant impact on disease-specific survival. Therefore, decisions regarding radioactive iodine in this subset of tumors should remain individualized, driven by other risk factors such as age and tumor size. Thank you, and I'd be happy to take any questions at this time.
Thank you for your presentation. This presentation is open for discussion. While we're waiting for people to come up. Dr. Volpi? Yeah.
Yes, I want to ask you, I really enjoy your presentation. Don't you believe that if one of the main limitations, as you told, is the dose of iodine and the reasons of why some patients did not receive and others received, don't you think that this is an important point to evaluate better the importance of this study? Because it's interesting to understand why some patients with huge tumors did not receive iodine therapy. It's interesting. I really want to know and if those patients have a recurrence or not, even though they don't have difference between the specific survival, the disease-specific survival, but the recurrence could be an important point to decide when do or not to do iodine therapy in some patients. Mm-hmm. What's your opinion?
Definitely. I think that, in this subset of tumors, this study was kind of the first study analyzing that. What we've seen in the low-risk category is there have been more clinical trials that have begun, like the ION trial that's currently underway in the UK. And I think that should continue to occur, especially in this intermediate risk category where we see the most conflicting evidence. And when you have a clinical trial, you are able to have all those details that are limitations in using this large database. So I think we've seen that in the low risk, and I think the benefit is pretty clear cut in the high risk when you have disease outside of the thyroid. But when it comes to these intermediate risk tumors, especially this subset where it is still confined to the thyroid, then I think more prospective studies that allow us to gather all the information necessary will be very fruitful.
Thank you.
We have a question.
Yes, Sam Snyder from Doctors Hospital, UT-RGV in Edinburgh, Texas. Thank you for your study. It's an in-depth study, and I can understand the results, but I think they might be a little misleading because you do not include recurrence. You know, that's just such an important factor when you're dealing with a patient with a tumor greater than 4 centimeters. So you reported that for these localized tumors, you had a certain population subgroup that had increased mortality. So if they have these localized tumors, why are they dying?
Yeah, I think, recurrence is something that, we have access to in the National Cancer Database, but not in the SEER database. But SEER database gave us the cancer-specific death variable, so that brought us to using that. I think, a study with recurrence is very important, especially for these intrathyroidal tumors that don't receive radioactive iodine, because, that is most likely the reason that leads to these patient deaths, especially once they've had a total thyroidectomy in most cases.
Hi, Ozzy Carr from University of Southern California, no disclosures. How did you define that they were N0? Did all these patients have some type of neck dissection, or were they just NX?
So we included all N0 and NX. Unfortunately, SEER does not have specific details on what type of neck dissection they had, just on the type of surgery, and that I think is also another limitation of our study. So we filtered based on the TNM staging that was recorded in the SEER database, which admittedly in some cases, might not fully represent the disease once it was more characterized pathologically.
It would be good to have that number of what percentage actually had an N0 versus an NX.
Yeah.
My apologies to those with questions. We're going to have to end discussion here. Thank you for your presentation.
Thank you.
For our third presentation, we'd like to welcome Kendall Carlisle to the podium, who will be presenting on age-stratified comparison of active surveillance versus radiofrequency ablation for papillary thyroid microcarcinoma, a decision analysis approach on behalf of Brown, Kim, Turner, Slako, Kuo, Mullins, and Hu.
All right, hello everybody. I would like to first thank AES for the opportunity to present our decision analysis study on papillary thyroid cancer. This study is supported by the NIH training grants, American College of Surgeons, and the University of Maryland Cancer Center. Papillary thyroid microcarcinoma, or PTMCs, are sub-centimeter papillary thyroid cancers. As evidenced by the graph on the screen, the incidence is increasing over time. PTMCs typically have a favorable natural history, and because of this, there are a few treatment options available, including active surveillance, radiofrequency ablation, and surgery. Several large active surveillance studies have shown an inverse relationship between age at diagnosis and rate of disease progression. This study from Miyachi et al. Shows a 10-year disease progression rate of nearly 37% for those in their 20s, compared to 3.5% for those in their 70s. RFA, over the last 5 years, has been gradually adopted as an investigational therapy for PTMCs. Although RFA is now FDA cleared, its therapeutic impact relative to active surveillance is underexplored. A randomized trial comparing active surveillance to RFA would be difficult because a large sample size would be required to detect small differences in clinical outcomes. Patients may be unwilling to undergo randomization, and long follow-up would be required, which is costly and time-consuming. Because of these difficulties, we decided to use a mathematical decision analysis model for this study. In mathematical modeling, we use current literature to predict future outcomes. First, we identify a question that's not easily answered in the literature, or that's not easily answered with a conventional trial. Then we do a literature review of the data. We create a mathematical model framework, and we input that literature into the model. Finally, we calculate our expected outcomes. This allows us to directly compare 10-year or long-term outcomes between RFA and active surveillance. The question, though, is what outcomes should we use? It's highly unlikely that survival will be impacted by either treatment option. So we engaged a community advisory board of community endocrinologists and thyroid cancer survivors to ask which clinical endpoints were most important to them. They highlighted 2 clinical endpoints: the desire to avoid disease progression and surgery, and the need for thyroid replacement therapy as a result of the thyroidectomy. Our primary objective of this study was to compare 10-year rates of disease progression and the need for thyroid replacement therapy between active surveillance and RFA using number needed to treat. Secondarily, we explored how age at diagnosis affected these outcomes and the corresponding cost of treatment. We hypothesized that RFA would be associated with lower rates of adverse outcomes overall, but that the number needed to treat would be higher for older patients. Here you see our mathematical model framework. In this model, patients move between health states over time. Health states are represented here by the yellow boxes. The arrows represent the likelihood of transitioning from one health state to another and would be assigned a transition variable. For example, the arrow from RFA to progression represents the transition variable progression rate of PTMC following RFA. Let's look at the model as a whole. Following treatment, a patient may remain stable, die, or progress. Following progression, a patient would have a partial or a total thyroidectomy. Rates of complications or need for replacement therapy would depend on the operation. In this model, time is represented by 1-year cycles. We ran the model for a total of 10 years. We had 4 main model assumptions. 1, we assumed that RFA's impact on progression relative to active surveillance was constant across all age groups because there are not currently published RFA age-specific progression rate data. 2, our RFA outcomes were limited to 5 years, so we assumed similar hazards of progression for years 6 to 10. 3, we did not account for multiple RFA treatments. And 4, we did not allow for crossover between treatment groups. Here you see our transition probabilities for disease progression with age on the left and treatment group across the top. Our baseline group in the top row is representative of median age PTMC patient or age 45. Important takeaways are that younger patients have a higher rate of disease progression and that RFA has a lower rate of disease progression across all age groups. The literature suggests that following progression, roughly half of patients will get a lobectomy and half a total thyroidectomy. Of those with a lobectomy, roughly half will require thyroid replacement therapy, and rates of permanent surgical complications and mortality were also included. Treatment costs were derived from Medicare reimbursement rates in Red Book, with major cost drivers, surgery, and RFA highlighted here. Let's look at some results. Our main results are here. On the x-axis, you see age of diagnosis, and on the y-axis, you see number needed to treat. Anything in blue represents our progression outcome, and in red represents our replacement therapy outcome. The baseline group is represented by these boxes here. 20 patients need to undergo RFA relative to active surveillance to avoid 1 case of disease progression, and 27.8 patients need to undergo RFA to avoid 1 case of replacement therapy. When grouped by age, you can see that the number needed to treat for both outcomes is less than 10 for age 20 to 29, but climbs to greater than 20 by age 50 to 59. The average 10-year cumulative cost per treatment was $6,400 for active surveillance and $11,700 for RFA. In the baseline group, our cost per progression avoided was roughly $100K compared to $150K for cost per replacement therapy avoided. In decision analysis models, sensitivity analyses allow us to detect real-world variability. And so here you see the sensitivity analysis for the outcome progression under our baseline group. Most simulations rendered a number needed to treat between 10 and 40, and a cost per progression avoided between 40 and 160K. Our sensitivity analysis for thyroid replacement therapy is shown here, where your number needed to treat estimate is between 15 and 35, roughly, and your cost per replacement therapy avoided is between 80 and 200K. There are several limitations of this study. First, we restricted to 10-year outcomes given the source literature. 2, we did not include quality-adjusted life years in this study because health state utilities for thyroid cancer are currently lacking in the literature. We are addressing this currently with a study to provide quality-adjusted life years for a range of thyroid cancer health states. And 3, we did not include temporary complications because our advisory board did not think they were critical to decision-making. In conclusion, compared to active surveillance, the therapeutic effect of RFA is most suitable for younger patients. Among patients 50 years or older, 20 or more RFAs need to be performed to avoid just 1 case of disease progression. And at a cost of $5,000, RFA may be cost prohibitive compared to active surveillance among older patients with current willingness to pay thresholds. I'd like to acknowledge my mentor, NPI, Dr. Yeon, and my co-authors for their support. I will take questions.
This presentation is open for discussion.
Quantu from San Francisco, a very interesting presentation of the new topics of active surveillance and radio frequency. My question for you is that, what about the lymph nodes? Are you assuming that ablating the cancer itself would avoid lymph node recurrences? Because the disease progression has two parts. One is the tumor itself grows, and the other one are the lymph nodes. My impression is that these are lymph nodes that are there from the very beginning. So doing radio frequency probably would not take care of that part of the progression. So did you take that into account?
Sure, I think that's a great question. So first of all, our progression rates for disease progression do include the rate of progression of the disease itself and possible lymph node mets. So that's really the only part of the model that does include lymph node metastasis. And so I think there would need to be more studies done to look at, if we're ablating these nodules greater than 10 years down the line, are there new lymph nodes?
Let's go to the front here.
Hi, Carrie Cunningham, Mass General Hospital, Boston. I congratulate you on your work. It's a difficult thing to present, I know from experience, so you did a nice job. One comment and a couple of questions that you may or may not be able to answer, so I'll preface it by that. First, I appreciate you and Dr. Hu actually trying to obtain quality of life measurement, because for thyroid cancer, many people survive with their disease for the rest of their life, and quality adjusted life years are critical, including financial toxicity in that. So I appreciate you doing that work. Question for you is the time frame of 10 years. There's very few patients that may progress or not, based on Dr. Miyuchi's work and others. So using that time frame may be a limitation. Please respond to that in the first question. And then go ahead, why don't you respond to that, and I may have a follow-up.
Okay, sure. I agree that that's one of our major limitations of this study. I think that, and I'm a little bit predicting the future with this answer, but should data show down the line that the treatment effect of RFA remains stable and you're not having these regrowths of cancer, and that active surveillance progression continues to progress throughout patients' lives, you would actually see with this model a larger risk reduction and a lower number needed to treat for progression. So I think RFA would continue to be appealing at that rate.
Exactly. And my second question is, and this is probably something that you won't be able to answer, is that we all know that thyroids are very complicated. They're one half, you can have many benign thyroid nodules, and the other half you could have a small MTC, et cetera. In the model, are you considering other types of cancers that potentially the progression could be from a tumor that didn't undergo RFA?
No, the simple question is this model is purely for PTMCs, and I think that it could be totally different if we were including things like missed MTCs.
Thank you, congratulations.
Mm-hmm.
We have time for one more question from the back on my right side here.
Perfect. Fantastic presentation, great work. It's counterintuitive, your final conclusion, that the people that benefit the most potentially from this are the young patients, and that's consistent with what we see in practice as we're offering this. What do you tell a young patient who is more likely to need a long-term of surveillance, multifocal disease, all of the things that we consider? Maybe this is not the ideal group that we want to treat as physicians, even though it's the group that may potentially benefit the most? I don't know how you really...
Sure. So I think an important emphasis is that in a patient with a 10-year disease progression rate of nearly 30-40%, we would probably offer surgery, right? If that is not something they were willing to undergo, I think that this study shows that RFA may be an alternative option for somebody like that. And so I think that is the framework that I would use to advise my patients. I wouldn't be going ahead and saying, well, we have this thing called RFA and we should just be using that on all our 20-year-olds.
Thank you.
Great job, thank you very much. So for our last presentation, I'd like to invite Peter Issa to the podium. Is that correct? It looks different than in the book. Okay. He'll be presenting comparison between thyroidectomy and thyroid surgery following radiofrequency ablation and benign thyroid nodules, a comparative analysis of surgical outcomes and safety on behalf of Omar Laforteza, Hussein, Abuisha, Shama, Torai, and Kandil.
Good afternoon. Foremost, I'd like to thank the organizing committee for putting on this conference, as well as the opportunity to speak here today. My name is Peter Issa. I'm a second-year medical student at Tulane University. And today we're going to be discussing thyroidectomy following radiofrequency ablation. Our study is entitled Comparison Between Thyroidectomy and Thyroid Surgery Following Radiofrequency Ablation in Benign Thyroid Nodules, a comparative analysis of surgical outcomes. We have no disclosures, or these are disclosures. Radiofrequency ablation is a safe and efficacious treatment modality for the management of benign thyroid nodules. Similar to what Dr. Volpi was saying, the popularity is increasing secondary to the advantages such as outpatient procedure. It's aesthetically pleasing, provides less risk for complication, and can be performed under local anesthesia. And finally, and perhaps most importantly, is its preserved thyroid function. Radiofrequency ablation, we have shown, is a safe and efficacious treatment option for the management of benign thyroid nodules in North America. Most eligible patients can be managed with a single ablation session. However, the vast majority can be managed with multiple treatment sessions. Now, there are a small minority of patients which require subsequent intervention following RFA, including surgery. It has been suggested that these patients undergoing post-RFA thyroidectomy, or PRT, may be at increased risk of complication. This increased risk of complication is secondary to the distortion of the standard neck anatomy, including the presence of adhesions and the distorted thyroid plane bed. However, a paucity of literature exists which investigates the specific subpopulation of patients. Therefore, it was our aim to conduct a comparative analysis to examine the increased perioperative risk, if any, in patients undergoing post-RFA thyroidectomy as opposed to non-RFA thyroidectomy. Now, as a comparative analysis, we have two cohorts. The first one are those undergoing post-RFA thyroidectomy. At Tulane, we have 522 patients undergoing radiofrequency ablation for benign indications. These are patients that are cytologically benign or that have genetic testing are benign. We found that 4.4% of these patients underwent subsequent thyroidectomy on the ipsilateral side, meaning that nodule was treated by radiofrequency ablation and then was subsequently subject to thyroidectomy. As you can see, if you turn your attention to the right, you can see the flowchart of PRT patients. A total of 522 with benign indications, 4% underwent ipsilateral PRT, and then you can see that on the left there is benign, and then on the bottom right there are malignant cases. These malignant cases are due to, these patients are initially benign on cytological analysis or genetic testing, and then on repeat biopsy immediately prior to radiofrequency ablation, as is conventional at our practice. They turn out to be suspicious, they undergo thyroidectomy, and they're determined to be malignant on surgical pathology. The non-RFA thyroidectomy cohort is going to be 2,022 patients undergoing consecutive thyroidectomy, conventional consecutive thyroidectomy. And so we removed those patients that had remote access, robotic surgery, or those with extensive lymph node dissection. So we will compare these two cohorts. First, we're going to go over the RFA procedural details and post-ablation response. You can see 5 millimeter and 7 millimeter probes were used. The majority of patients, 90%, underwent a single ablation session, and the max volume reduction rate by patients was 48%. So as you can imagine, those patients undergoing post-RFA thyroidectomy are those that did not have a great response or a suboptimal response. And then the mean time to thyroidectomy was 7 months in this cohort. Here are the indications for thyroid surgery, and if you look at the top right, you can see those patients which had suboptimal volume reduction rates, and they contributed a significant proportion of the patients. In the bottom left, we have those with positive molecular testing, and in the top left, we have those with persistent hyperactive thyroid nodules which failed treatment. As we turn our attention here, you can see in the third column is the NRT. Just want to remind you that's the non-RFA thyroidectomy, and column 4 is the PRT, the post-RFA thyroidectomy. And we can see that the demographics with respect to sex, race, and BMI are all similar. With respect to any comorbidity and the specific types of comorbidities, they are similar. And finally, the presence of toxic nodules and nodule size and the preoperative workup were similar between the two cohorts. So they are comparable. With respect to procedure, the type of procedure, as well as the hospital length of stay, whether a same-day discharge or if they stayed overnight, were similar between the two cohorts. And finally, the mean operative time and post-TSH values, just under 2 hours for the operative time, were similar between the two cohorts as well. So we've established that these two cohorts are quite similar. Let's turn our attention to the complications. With complications, we can see the incidence of complication in the overall cohort is between 11% and 13%. And this was similar between the two study populations. The specific complication itself, including hematoma, seroma, transient dysphonia, permanent dysphonia, transient hypoparathyroidism, and permanent hypoparathyroidism, were all similar between the two cohorts. Now, it's understandable that the risk of malignancy or the risk of complication differs between those nodules which are benign and those nodules which are malignant on thyroidectomy. And therefore, we conducted a subgroup analysis, including those patients with just benign thyroid nodules on surgical pathology and those with malignant thyroid nodules on surgical pathology. Here is our report. Here's our report on the benign surgical pathology patients, and you can see once again, any complication is between 11 and 12%, and similar with any type of complication, hematoma, seroma, etc. As we turn our attention to the malignant surgical pathology cohort, we see a similar idea, a similar risk of complication, and similar type of complication across the board. Finally, to finalize our analyses, we conducted a multivariate regression analysis to determine independent predictors of complication following thyroidectomy. In this cohort, in this analysis, we found no significant predictors of complication. In specific, if you look at the prior RFA, or so the PRT versus the NRT cohort, there was no increased risk. And if you turn your attention to malignant versus benign, once again, there was no increased risk. To quickly summarize, we found that only 4% of patients, 4.4 to be specific, underwent PRT in our cohort, leaving 96% of patients undergoing radiofrequency ablation for benign indications able to obviate the need for surgery. There were no differences in perioperative outcomes between the two cohorts, and then when we conducted subgroup analyses for benign surgical pathology and malignant surgical pathology, we found there were similar risk of complication. It's important to note that there was no permanent complications overall in either cohort as well. So to conclude, our work suggests that there is no increased risk of perioperative complication related to thyroid surgery following radiofrequency ablation. And importantly, the authors recognize that this study is one of the earliest, if not the earliest, and we strongly recommend future multi-institutional studies with larger sample sizes to confirm and expand on our findings. I'll take any questions.
This presentation is open for discussion. We'll start in the back.
Aaron Berber, Cleveland, Ohio. Congratulations on your work. I have two questions. If you could summarize your indications for RFA up front in those patients, and also...
Oh, would you like that slide?
No, if you maybe indications for RFA, when the patient presented, like nodal size or symptoms, and also when you decided to do surgery in follow-up, if you could tell us about your clinical strategy, what really prompted you to consider surgery in those patients, and how long would you wait after ablation to decide for that?
Yes, sir. Yes, sir. Thank you, Dr. Berber. That's a great question. So as we know, volume reduction rates typically they increase substantially till 6 months, and then they kind of slow down after 12, with some studies showing 24, but that's neither here or there. If patients had suboptimal volume reduction rates, as we showed, it was 48 in this cohort, they are strong. After 6 months, they are potential candidates, and it's obviously a discussion with the patient. It's important to note that our median time to thyroidectomy in this cohort was 7 months. So we gave these patients ample time. We informed them, we have that discussion, and then they decide to proceed with thyroidectomy. The other cohort was the toxic thyroid nodules. You give these patients 1 or 2 months, you can see the TSH levels, you monitor them closely, and if you can see that the TSH is still low, they're hyperactive, perhaps it's time for another radiofrequency ablation, and you have that conversation with the patient. Thank you.
Salim Nuruddin, Washington, D.C., Noble Disclosures. I enjoyed your talk. One thing you did not share with us is your technique for RFA. Do you inject saline or local anesthetic in the planes around the thyroid? Does that affect anything? How many of those nodules were located posteriorly, and did that make the dissection around the ligament of Mary more difficult? And lastly, did you look at your rate of autotransplantation as a surrogate for how difficult those procedures could have been? Thank you.
Thank you, Dr. Nuruddin. I'll try to answer them one by one. So the exact number of how many are in the danger triangle, paratracheal deep, I do not know off the top of my head. We can chat and discuss afterwards. The technique that Dr. Kendall supports is actually a short axis approach, and that's the direct axis approach instead of the transisthmic. He approaches it actually laterally to medially. This is his standard and his comfort. Almost over 600 nodules now, and so he's very comfortable with this approach. In that sense, he appreciates the opportunity to treat the most paratracheal, medial, deep portion last. And so that's the way he goes about this procedure. Thank you.
In the front.
Richard Harding, Phoenix, Arizona. I would interpret some of that 4% as perhaps treatment failure. And in order to understand the rationale for a reason for treatment failure, I'd look at the joules per ml applied for those nodules compared to the the patients that were not treated. I was just curious if you had information on that.
Thank you, Dr. Harding. So that's a great question. Actually, we have some colleagues, a multi-institutional study coming up with some colleagues, and they will provide some predictors of complication, predictors of success. Thyroid nodule size, a small thyroid nodule size is one, as well as delivered energy joules. At our institution, we've only recently implemented, being providing that emphasis on how much joules. It was discussed at the last NASID, and since then we've decided to be meticulous with that collection. We don't have that. We have the size, the access, and the operative time, but we do not have specifically the power or the joules per se. Thank you.
We have time for one more question.
Brendan Finnerty, New York. Very nice presentation. Unless if I missed it, do you have any more granular details about the malignancies that were ablated? Specifically, if the pathologist was comfortable with the amount of tissue that they were able to make the diagnosis with, and if you experienced any higher rates of extrathyroidal extension or positive margins, things of that nature.
Yeah. From what I can tell you is all of these, they're not per se incidental malignancies is what I will say, but they were all less than 1 centimeter or less. And so when you biopsy the first nodule the first time, and when the patient comes on their first encounter, comes back Bethesda 2, or it's Bethesda 3, a TP of undetermined significance, goes to cytogenetic genetic testing and it comes back as benign, less than 4% risk of malignancy, and we continue with RFA. The same day of RFA, we do another biopsy, and then we determine, perhaps if it's 3 or 4 or whatever it is, Bethesda 3 or 4, we determine that we need to perhaps, and have that conversation, proceed with surgery. These nodules, the average size for that cohort was around 2, so you can imagine those are those specific patients. As for the positive margins and indications like that, none of those patients underwent central neck dissection, lateral neck dissection, anything of that nature. It was just a small, all of them were PTC. But beyond that, I don't have, exact numbers off the top of my head. Forgive me. But we can get to that. Thank you.
Thank you very much.
Yes, sir.